My name is Nausheen Akhter. I am an assistant professor at the Bloom Cardiovascular Institute, Northwestern University, and the director of our Cardio-Oncology program here. The topic of today's talk will be improving patient management in cardio-oncology, latest recommendations, and strain imaging. An overview of what we will be discussing today, generally, what is cardio-oncology, how to develop a cardio-oncology practice, what is myocardial strain imaging. We will touch on the ASC consensus statement and standardization task force for cancer treatment and strain imaging, and then finally end with some very interesting cases. Cardio-oncology is a bridging field that is growing alongside cancer survivorship. With increasing cancer survivorship, cardiac toxicity can be the primary determinant of quality of life and mortality. A patient with early-stage breast cancer is more likely to die of heart disease than of cancer. The goals of a cardio-oncology practice are to, 1, provide seamless care between cardiology and oncology services for cancer patients with cardiovascular issues, 2, to improve patient outcomes by developing structured management algorithms for cardiac toxicities, to prevent or minimize the cessation of chemotherapy, and 3, to provide state-of-the-art advanced left ventricular assessment with emerging technologies to all oncology patients at risk for developing adverse cardiac outcomes. There are two primary models for a cardio-oncology practice. One is where the cardio-oncology practice is actually physically located in an oncology clinic. There are several pros to this approach. Obviously, there will be more interaction between the physical interaction between the cardiologist and the oncologist. It is more convenient for patients to have all their doctors in one location. And there's a greater staff familiarity with the oncologic disease, side effects of chemotherapy within the oncology clinic. The cons include access to cardiology testing. However, if the oncology clinic is open to the idea and there's enough volume, potentially an echocardiography machine could be located within the oncology clinic devoted to cardio-oncology studies. The second model, and this is the model that we have here at Northwestern, is where the cardio-oncology practice is located in the cardiology clinic. The pros to this approach are that the staff within the cardiology clinic are familiar with cardiac conditions such as heart failure, and that there's more real-time access to cardiac testing. EKGs can be done within the clinic. Echocardiograms, potentially stress tests, could be done within the clinic. And these studies can be reviewed in real time to make clinical correlations and diagnoses. The cons to this approach is that the cardiologist does need to be more proactive in reaching out to the referring oncologists, nurse practitioners, advanced practice nurses, to educate them and to bring visibility to the practice. There also needs to be more flexibility on the side of the cardiologist in terms of scheduling patients who may desire to see all of their doctors on the same day if they're coming to see the oncologist or if they're coming for chemotherapy treatment. And so this may not necessarily fall into like a strict clinic time, and so the cardiologist may have to find different times to see the patient. Some of the reasons for referral to a cardio-oncology practice include during the pre-anti-cancer therapy time period, an evaluation of patients with known cardiovascular disease, those who have a history of coronary artery disease, valvular heart disease, heart failure, arrhythmias, to see them, to take any precautions before starting chemotherapy to make sure it's okay to start treatment. Some of the indications during or ongoing anti-cancer therapy include, and this is probably the primary reason for referral, is development of LV dysfunction, whether symptomatic or asymptomatic on treatment, chest pain, including evaluation for ischemia and vasospasm, hypertension management, assessment for pericardial disease, including pericardial effusions, as well as constriction, arrhythmias, or QT prolongation. And then post-cancer therapy, determining long-term cardiovascular risk and how that's changed based on the treatment the patient has undergone. Now, switching gears to myocardial wall motion and strain, we have to step back and think about how the left ventricular myocardial fibers are oriented. The endocardium is primarily made up of longitudinal fibers. So from endocardium to epicardium, you have longitudinal fibers. And then in the mid, approximately 1/3 of the heart wall, you have more circumferential fibers. And this is important in understanding the principal vectors of left ventricular strain, which include longitudinal, circumferential, and radial. And then before even discussing strain, the standard by which we determine what is normal and abnormal in the realm of cardio-oncology right now is by ejection fraction. So what is a normal ejection fraction? Normal EF actually is, the range is slightly changed now based on some new data from 6 different databases. The Simpson's biplane method of discs defines the range now between 53 to 73%, and the assessment of EF could also include could also be combined with a wall motion score index. So cancer therapeutic related cardiac dysfunction, or CTRCD, is then defined as a decrease in LV ejection fraction by greater than 10% to a value less than 53%. And it can be subcategorized further into reversible, partially reversible, and irreversible. We all know that there are limitations to left ventricular ejection fraction assessment, and that subtle changes in LV systolic function may not necessarily be detected by ejection fraction. Image quality and precise endocardial border definition may be problematic, and this is especially true in our patient population. Breast cancer patients, as we know, post-mastectomy, radiation, they may have breast expanders or implants that make it technically difficult to visualize the left ventricle, and where you're unable to maybe truly visualize the endocardium and the LV apex. Loading conditions are also important in ejection fraction, whether the patient is volume contracted from nausea and vomiting and poor PO intake. All these things are things that limit our ejection fraction assessment. And so what is the difference between wall motion versus deformation? Well, wall motion cannot distinguish between active and passive motion. However, deformation can distinguish between active and passive motion, and oftentimes deformation is thought to be what the eye cannot see. Strain is is our term for myocardial deformation. So strain is defined as the total deformation during a cardiac cycle relative to the initial length at the onset of the cardiac cycle. It is a dimensionless number and expressed as a percentage. So this is a cartoon depicting strain, which we see an example of a myocardial fiber at end diastole and end systole, in which strain again is defined as the change in this length over the initial length. Lengthening and shortening the longitudinal are defined as negative percentage, and thickening and thinning in radial is defined as a positive percentage. Here is another cartoon, again showing the equation for strain, and that the percentage of change in length of the myocardium during relaxation and contraction is what we are measuring when we measure strain. Deformation imaging, or strain imaging, has two components: tissue Doppler and speckle tracking. Tissue Doppler imaging was the first form in which strain imaging evolved. And tissue Doppler, we'll spend a few minutes discussing that, measures the velocity of the myocardial tissue with a wall filter. High-pass filter images the blood velocities, and low-pass filter images tissue velocities, and it eliminates the high-velocity signals. The problem with tissue Doppler imaging is that it is single-dimensional, and so alignment with the ultrasound beam with the wall is very important. As you can see here in the picture, the measured velocity, which is the yellow arrow, can be underestimated if the ultrasound beam is not aligned with the wall. In order to improve this measurement, the sonographer can narrow the sector and give you just a single wall acquisition, thereby decreasing the angle of incidence. However, now we are more often using speckle tracking to measure strain. And speckles are the natural acoustic markers that are distributed within the myocardium. By using standard B-mode imaging, the speckled pattern, which is picked up by the acoustic backscatter generated by the reflected ultrasound beam, is followed frame by frame using a block matching technique. This displacement of the speckled pattern is considered to follow the myocardial movement, and the change between these speckles represents myocardial deformation. And so we can see that here in this picture, where we have a frame and then the next frame in which the acoustic markers, or the speckles within the myocardium, are followed, in which we then track these speckles to determine the deformation or the strain of the myocardium. The advantage of speckle tracking over tissue Doppler imaging is that speckle tracking tracks in both 2 and 3 dimensions and is angle independent. It provides longitudinal, circumferential, and radial parameters, and can also give you epicardial, mid-wall, and endocardial measurements. A software algorithm that follows a defined region of the speckles frame by frame and extracts the displacement, velocity, strain, and strain rate is used. The frame rate for optimal speckle tracking strain is between 40 to 90 frames per second. A lower frame rate may result in actually undersampling, which is a loss of speckles in these successive frames. Speckle may move out of plane, in which then it's lost if there are too few frames and can't be tracked. The variability between tissue Doppler imaging and speckle tracking is shown here, in which the inter-observer variability is better for speckle tracking. And so the advantages of speckle tracking, again, are that it is angle independent, can provide both 2 and 3 dimensional values. It can give you longitudinal, circumferential, and radial strain, and has better variability than tissue Doppler imaging. Limitations include that a low frame rate can cause undersampling, and a high quality image is necessary because with technically limited studies, the strain will also be technically limited. There are also differences between vendors. Within the Epsilon software, you can really break down obtaining strain into 3 5 steps. Step 1 is to define the region of interest, in which you manually trace out the wall. By tracing out the endocardium of the left ventricle, it provides the region of interest. Right next to that, you can either adjust the trace or exclude a segment. Step 2 is to review the qualitative information by region of interest. It's color-based with an epsilon. The systolic color is blue. You can also select the wall detail button, and that provides further qualitative information that's broken down into 6 segments. So step 3 is to review the strain curves and to make sure that the strain curves are appropriate. It's divided up here into 6 segments, 6 color-coded segments, and then the regional strain on each of those segments lays on the left ventricle. And these are the end-systolic strain values for this particular image. And here is a moving version of that where you can see the change in color from blue to red, and as we walk through the cardiac cycle. The strain curves can also be reviewed in the apical 4, 2, and 3 chamber views, as well as individual longitudinal strain value for each of these views. Finally, the next step is a quantitative information, which we can get the ejection fraction, as well as the chamber sizes, as well as the volume, and some of the hemodynamic information from the echo. And then finally, our final step is to review the bullseye, which is presented on a summary page, in which here, when the bullseye is completely blue, indicates normal. The global strain represents an average of the 4, 3, and 2 chamber views, and it can also be subdivided into apex, mid, base. You have your LV global function plot, which, when there's a comparison study, can show you the change in strain and change in ejection fraction, which is a very useful visual. Here is a picture just showing the difference between radial and circumferential strain. Radial, again, is the thickening and thinning of the myocardium, and it's represented as a positive strain. Circumferential is more of the LV twist, and it's represented as a negative strain. American Society of Echocardiography came out with a expert consensus statement for multimodality imaging in adult patients during and after cancer therapy this past fall. Within this consensus statement, they suggested a cardio-oncology echo protocol, which is summarized on this slide, and this is directly taken from a table from that document, in which they suggest that the global longitudinal strain be reported, on what is sort of the optimal frame rate to obtain that, and if you desire to also to quantify segmental strain, display the strain curves as well as the global bullseye plot, some of the pitfalls to obtaining strain, and that if information such as timing of the echocardiogram through chemotherapy infusion is there, number of days before and after that may be useful to report, along with vital signs, 3D LVEF or 2D Simpsons-Blyplane EF method. And then in the absence of having strain at your hospital, the measurements of medial and lateral S' and MAPC can also give information about longitudinal changes in LV function. This is a table taken from that document showing the normal global longitudinal strain values based on 3 different vendors, by age and gender. So this can be validated within your own laboratory to determine what the norms are for your laboratory. Generally, approximately negative 20% is considered a normal global longitudinal strain value. Epsilon has also looked at the relative differences between different vendor data, and this slide shows the relative differences based on Epsilon imaging strain. When we talk about CTR-CD, it can be divided into a type 1 and type 2 toxicities, and this is mentioned in the consensus statement document. Type 1 toxicities are those chemotherapies that cause irreversible damage to the left ventricle. Generally, these are the anthracycline chemotherapies such as doxorubicin, epirubicin here. Type 2 toxicities are those that that do not cause irreversible. So there's a reversible change, and generally a reversible change in LV dysfunction with these types of anti-cancer therapies, and in which the American Society of Echo suggests an integrated approach depending on the type of chemotherapy toxicity in terms of evaluating, managing, and following these patients. The initiation of the regimen, for example, a patient who comes to you with a doxorubicin regimen, you'd want to get a baseline ejection fraction, if possible, global longitudinal strain value, and a troponin at baseline, and then follow the patient. If there's a decrease less than 53% or a global longitudinal strain less than lower limits of normal or a positive troponin, consider cardiology consult. However, if those values are normal, then repeat an echo at the completion of therapy and then once again 6 months later. For trastuzumab or Herceptin, the baseline is obtained and then follow up every 3 months on treatment. So patients who receive a year of treatment are getting 5 echoes that year, in which we're following ejection fraction, strain, and potentially following troponins as well. Those patients who are getting type 1 agents, the anthracyclines, followed by trastuzumab, we're following these patients in a similar manner as those in the last algorithm, which we're following them every 3 months on therapy, and then at the end of therapy and 6 months later. The ASC suggests that a relative drop of global longitudinal strain compared to baseline of greater than 15% indicates subclinical LV dysfunction, and this is assuming that there's a less than 10% drop in ejection fraction. What do we do with that patient group is still an area of ongoing research. Whether that group is followed more closely or we introduce a neurohormonal treatment at that time is still an area of research. A special standardization task force was also developed, and this is a technical document that came out this past February, in which the task force is essentially developed to standardize physical and mathematical definitions of strain parameters, and is really aimed at the technical community. Epsilon Imaging and other vendors participated in this effort, and the goal of this effort is really just to reduce interventor variability in strain measurements. We'll move on to our cases. Case 1 is that of a 67-year-old man. He has a past medical history significant for hypertension, moderate aortic stenosis. He also has a high-risk genotype of acute myeloid leukemia, and he's enrolled in a clinical trial to receive 7+3 chemotherapy, which is the standard chemotherapy given to AML patients. In that chemo regimen, there's 3 cycles of anthracyclines administered. And so what we see here is on the left-hand side, the patient's baseline echo, and on the right-hand side, the follow-up echo post-chemo treatment. And so we can see that the LV cavity size is larger. The ejection fraction decreased, as well as the strain, which should follow a decrease in ejection fraction. The change is again seen here on the bullseye plot, as well as the LV global function plot, in which we see the decrease in both the ejection fraction and the strain numbers between pre and post 7+3 treatment. And so really this case highlights that even low doses of anthracycline treatment can be harmful. And although there is a cutoff for patients, or lifetime cutoff for anthracycline treatment, that we should be assessing patients regardless of any sort of dose of anthracycline given. In particular, this patient may have been further primed for changes, given changes to the left ventricle in advance due to the valvular heart disease that he had, as well as the hypertensive heart disease. This is actually a study that we did. We actually looked at this particular patient group here at Northwestern, in which 25 patients were enrolled in the ECOG 2906 study between 2011 and 2014, and we studied older patients with AML who received 7+3 treatment versus a newer chemotherapy regimen. They were randomized into this other chemotherapy regimen that did not have an anthracycline within it. And we did find that there were changes noted, significant changes noted in the 7+3 arm in global longitudinal strain, as well as very significant in the 4-chamber longitudinal strain, and as well as decreases in ejection fraction as compared to the other arm that did not have the anthracycline. And so these findings suggest that LV changes occurred just shortly after exposure to relatively low doses of anthracyclines in older patients with AML. And we need to study this group further to investigate if these changes affect long-term outcomes in this patient group. Our second case is that of a 55-year-old woman with hypertension. She also has left-sided breast cancer and was treated with ACTH, which is the anthracycline, adriamycin, Cytoxan, and TH includes Herceptin, and she's currently on maintenance Herceptin. And so her baseline echocardiogram shows completely normal ejection fraction, 60%, normal global longitudinal strain of -21%. And here the patient has been given contrast to highlight the endocardium and give us a better assessment of her heart function. And here is the global longitudinal strain for this patient with -21%, as mentioned. Something that is in development is evaluation of strain on patients who have been given contrast to help improve evaluation of the ejection fraction. And so this is something that is in development here. Is an example of a a research study on this particular patient where we're looking at the longitudinal strain obtained here is negative 22% with very normal ejection fraction. Our next echo on this patient, so she is on Herceptin, so she's getting an echo every 3 months. Her next 3-month surveillance echo then shows, still looks like the ejection fraction is preserved, maybe has changed very slightly, but nothing that it looks like it's a gross change. However, there's now a change noted on her global longitudinal strain, so it's gone down from negative 21 to 22% to negative 16%. And here is the strain curves in the bullseye showing the change in her strain at the 3-month point. At 6 months, her ejection fraction is clearly diminished, and so now it's at 40%. And so this case highlights where, the exciting area in cardio-oncology for strain. We're using, we can trend the strain values during treatment to prognosticate potential changes in ejection fraction that follow changes in strain by 3 to 6 months later. Our next case is that of a 64-year-old female. She has a history of lung cancer and non-obstructive coronary artery disease. She also has a history of ejection fraction of 40%. You're told that she has non-ischemic cardiomyopathy, and now she's presenting for evaluation of dyspnea, and a differential for this patient is very broad for dyspnea. And in part, in the evaluation, you obtain an echocardiogram. And so on this echocardiogram, you see a apical 3-chamber as well as a peristernal short axis view. And so, on first glance here, yes, the LV function looks diminished and at around 40%. Then we do strain evaluation on this patient. Lo and behold, we actually see that there is a change here in regional strains. If you look at the strain, it's divided into 6 segments. Again, this is an apical 3-chamber view, and so the basal infralateral wall is red, the mid infralateral wall is a light green. What we see here is that the strain is diminished in the basal to mid infralateral segments as compared to the rest. And that may not have been apparent on first glance of this echo, but the strain really helps bring out the change in the wall motion here on this patient. And we see the regional change in strain on the basal to mid anterolateral wall as well in comparison to the septum. So there is definitely a regional wall motion abnormality here on this patient, and we see it again on the bullseye plot where the anterolateral and the infralateral strain segments are reduced in comparison to the septum and the rest of the heart. The global longitudinal strain value for this patient is negative 15%, which is diminished, and her ejection fraction was 44%. And so that case is really to highlight that the strain can help with not just the global change, but the segmental changes in strain can really help the clinicians sort of zero in on changes in wall motion and further the assessment of dyspnea on that patient. Our next case is a 51-year-old woman. She has a history of Hodgkin's disease, was treated in 1989 with a treatment that is not given anymore, MOP-ABV. which also includes anthracycline within that regimen, as well as mantle radiation, which is a large field of radiation, including chest, axillary lymph nodes, and neck. She presents to you for evaluation of severe symptomatic mitral regurgitation. The echo image is a 4-chamber apical view and a zoomed-in view of the mitral valve. We see the changes to the mitral valve structure due to the prior radiation treatment. We see this calcification along the anterior base of the anterior mitral valve, as well as the mitral valve leaflets are both very thickened and tethered. With color Doppler, you can see the patient has a severe degree of mitral regurgitation filling up the entire left atrium. When we did strain on this patient, interestingly, the anterior and anteroseptal part of the heart here, we see decrease in strain numbers. And so this is also more prominent along the base. It corresponds to the changes that we saw on the patient's mitral valve. And so another potential use here for strain in patients who've had prior radiation treatment is to another potential way to evaluate patients is with strain to see where the changes in structurally are affecting the heart from prior radiation. Case 5 is our final case. It's that of a 27-year-old woman. She has a history of breast cancer left-sided. She's had bilateral mastectomies, undergone chemotherapy again with anthracycline. She had a special type of chemo treatment was given to her. It was dose-dense chemotherapy, in which her chemotherapy was given in 2-week intervals instead of 3-week intervals. And so that's, done for 2 reasons, really, to not allow time for cancer cells to return, and also decreases the duration of time in total that the patient needs to get the AC treatment. This was followed by 4 cycles of Taxol. She had radiation, and she's currently receiving Perjeta and Herceptin because she has, this particular patient has metastatic disease. She'll be on the Herceptin maintenance for, years. So this patient had a history of cardiomyopathy on treatment, was started on neurohormonal treatment with beta blockers and ACE inhibitors. Her last echo showed improvement in normalization of EF and her global longitudinal strain. As you can imagine, being on treatment long-term can get tiresome for patients. They may feel like they need drug holidays. So she ended up running out of her Ramipril, her ACE inhibitor, and ended up not filling it. When she came in for her echocardiogram, we found a change in her strain from negative 23% on the last echo to negative 16%. Although her ejection fraction remained preserved, this potentially suggests that this change in strain was seen due to her non-compliance with her heart failure treatment. And so another a potential use for strain is to follow compliance on patients. In summary, cardio-oncology is a burgeoning field that incorporates advancements in echo technology and patient management. Global longitudinal strain is our strongest prognostic parameter in varying oncologic conditions and types of anti-cancer agents. Standardization and vendor-neutral platforms will lead to a reduced variability in strain imaging. And there are yet many uses for strain in cardio-oncology that can be explored. Thank you.